Thank you, everyone. I think that if we start the seminar now, so good afternoon. My name's Eric Carlin, and I work as part of the alcohol team at the WHO office, regional office for Europe, working on alcohol policies. I'm really delighted to welcome you to this webinar, which is the latest in a series of webinars which is being held as part of the WHO European Union Evidence into Action Alcohol project funded by the European Commission. And EvidAction's objective is to use scientific evidence to promote and facilitate the implementation of effective alcohol policies in the EU, Iceland, Norway and Ukraine. The title of today's seminar is Alcohol Inequalities and Inequities, Evidence and Policy Options. And it's a very important theme. We know that alcohol consumption, that some of the main harms that it causes particularly affect those who are less equal in society. And we also know that the best buys, the evidence-based measures to reduce alcohol-related harms very often can actually act to reduce those health and social inequalities that are absolutely avoidable due to alcohol consumption. So the format for today's session, as with previous sessions, is that we will have two speakers and then we will have opportunities for some chat and discussion. The whole seminar will last an hour in total. If you do wish to ask questions, to make points, I would encourage you to do that using the chat function and also the question and answer function. And we will pick up in the course of the session any points that are raised there, and hopefully we will have plenty of time within the session to cover everything. So I'm delighted that today we will be welcomed by Dr. Jakob Manthey, researcher at the University Medical Center in Hamburg, Germany, and also Dr. Charlotte Probst, who is an independent scientist at the Center for Addiction and Mental Health in Toronto, Canada. So without further ado, I'll pass over to Jakob. And Jakob, I think you're going to share your own slides. So thank you.
No, it's Charlotte, but thanks anyway.
Apologies.
No problem. Charlotte, can you share?
Okay, so now I should be unmuted and you should all be able to see my slides. Can you give me a quick nod? Okay, great. So hi everyone, thanks for having me and welcome to this webinar on alcohol inequalities and inequities. I'll be talking about the evidence on inequalities as of now, and then Jakob will take over to talk about policy options. And I thought it would be a fitting start to maybe first define the terms inequality and inequity so we know that what we are talking about today. And inequality describes an unequal or uneven distribution of health outcomes across different population subgroups. Whereas on the other hand, inequality describes an uneven distribution that is avoidable, unjust or unfair. So if we think about furthering equality or equity, equality means providing the same resources to everyone, as shown here on the left. Everyone is supported by the same resources, whereas equity would mean adapting the intervention and resources to the needs of the different population groups. Oops. And with that, health equity is achieved when everyone can attain their full potential for health and well-being. And today I'm going to mainly use the term inequality. As epidemiologists, we're kind of used to using the more neutral descriptive term. However, I do believe that all or most of the inequalities that we will be describing today are in fact avoidable and unjust. So inequity would be just as fitting of a term. So let's start with looking at some of these inequalities. And here we look at the gap in life expectancy at age 30 between low and high level of education in different European countries. And this is data from 2016. And the first thing that you can see is that there is a tremendous gap in life expectancy between those with low and high education, that this gap is higher among men, which are shown in the darker bars, than among women, which are shown in the lighter bars. So those with less than secondary education can expect to live about 7 years less than those with a tertiary education among men. This is the EU 14 for these 14 countries average. And then for women, it is a 3-year gap. You can see that the gap in life expectancy is higher in Eastern and Central Europe. And for example, in Slovakia, Poland, and Hungary, 30-year-old men with a low level of education can expect to live more than a decade less than those with high education. Now, when we try to understand this gap in life expectancy, one step that we can do is to look into the causes of death that are most contributing to the observed inequality. And this has been done by Mackenbach and colleagues in a paper published in 2015, in which they investigated the relative mortality risk, so the mortality risk or mortality rate among those with a low socioeconomic status divided by the mortality risk among those with a high socioeconomic status. And here again, they used education as indicator of socioeconomic status to get the relative risk of cause-specific mortality. And here this is averaged for, or I think it's the median for 19 European countries. And this is all data from the first decade of the 21st century. And the relative risk refers to women on the left and men on the right of the ages 30 to 80 for 24 causes of death. And what you can see here is that for all causes that are shown, the relative risk is at least 1, which would indicate equal mortality rates or mortality risks. But in most cases, it is above 1, indicating higher mortality risks among those with a low socioeconomic status. And noticeably, alcohol abuse is at the top here, both among women and men. And that, of course, indicates that alcohol-related causes of death, in this case alcohol abuse, seems to be associated with more relative inequality than other causes of death. We have looked into this in a systematic review and meta-analysis that was published quite a few years ago by now, to 2014. And in this, we compared the relative risk for alcohol attributable causes of death, and these are all 100% alcohol attributable, to the relative risk in all-cause mortality. And this is again relative risk comparing low to high socioeconomic status for different indicators of socioeconomic status. And here in the top we have men, and in the bottom we have women. And then you see the different indicators of socioeconomic status. And the values circled show the average across different indicators of socioeconomic status. And basically this shows that the relative inequality in alcohol attributable mortality is 1.7 to 1.8-fold higher than the relative inequality in all-cause mortality, again demonstrating that there is higher inequality in alcohol attributable outcomes. Now, this is averaged across studies and across countries, but let's look a little bit into the profile for different countries. Here we see again data from 17 European countries. These are alcohol attributable mortality rates, again from a study by Mackenbach. And the mortality data are again from the first decade of the 21st century. And these are mortality rates, deaths per 100,000 person years. So these are kind of absolute inequality, where you can see the rate among low, middle, and high SES. And again, this is education as indicator of socioeconomic status. And what you can see is that there is quite a variation in the mortality rates, and thereby also in the contribution to the overall inequality by different countries. And if you look at those countries here with a very high rates among those with a low socioeconomic status, but also overall, these are countries with a very high per capita consumption of 12 to 15 liters. And here I use the alcohol per capita data, total alcohol per capita consumption from 2010 to sort of match the time frame for the mortality data. And then if we compare that to those with lower mortality rates, these have alcohol per capita 7 to 10 liters. And that basically tells us that alcohol is a major contributor to inequality in countries with high per capita consumption, such as Baltic countries. Now we try to look into this risk relationship, the relative risk relationship, again in a meta-analysis to kind of describe this relationship between socioeconomic status and the relative risk of dying in a more uniform way. And what we did here is to use a systematic review and meta-analysis to generate these dose-response relationships. And here we indicate the level of socioeconomic deprivation as the highest level of deprivation, indicating the lowest level of, for example, education on the left or income on the right. So here at the 80th or 100th percentile would be the people with the very lowest income or the lowest education. And at the 0, of course, there are those with the highest education or income. And then you see the curve for women and for men. So the men are shown in the dotted line. And basically what you can see is that for these different indicators of socioeconomic status, the risk relationship looks a little bit different. But in both cases, you have an increased risk. Here for education, it is threefold or more than fourfold for men of dying at the midpoint of the socioeconomic distribution already. And for income, that is similar, especially among men. You already have a relative risk of dying from an alcohol attributable cause of death that is 2.5-fold compared to those with the highest socioeconomic status among men. And that is already at the midpoint of the population. And why I think is it important? It's to show that this is not a phenomenon that only concerns those at the very end of the socioeconomic distribution. It concerns really the whole spectrum of the socioeconomic distribution in the population. Now, one may think that if individuals with a low socioeconomic status have such a higher risk of dying from an alcohol attributable cause of death, they must be drinking more. So we can explain these differences by drinking patterns. And that is what we have tried to do in another systematic review, where we summarize all studies that would tell us something about how alcohol consumption, both the average level of consumption as well as drinking patterns, can explain differences, the socioeconomic differences in mortality. So if we account for the fact that potentially individuals with low socioeconomic status drink more, can we explain the observed differences in mortality? And here on the y-axis, you can see the percent of the inequalities that can be explained. And here I list the different studies that were included. And those studies here in the light gray, blue, they accounted for drinking as average quantity per week or per month. Then as we move to the right, those with the one study here with the dark blue indicator accounted for quantity consumed per occasion. Those studies shown in purple use the combined indicator of average consumption and heavy episodic drinking. And then those shown in red accounted for heavy episodic drinking. And what that shows us is that the more we account for the drinking pattern, the more inequalities we are able to explain. However, none of these studies explain more than 30% of the observed inequalities. And that, of course, means that the drinking pattern alone is insufficient to explain the observed inequalities, and that there may be a differential vulnerability to the harmful effects of alcohol use, conditional on socioeconomic factors. And overall, we also know that individuals with low socioeconomic status are more likely to be abstainers. They don't necessarily have higher levels of average consumption, but among the drinkers, there may be more heavy drinking and more heavy episodic drinking. So I would like to invite you to kind of broaden the focus a little bit from focusing on the individual and its individual risk behavior and in explaining the outcomes. So basically explaining the inequalities only via alcohol consumption, to consider also other individual risk behaviors that may cluster in individuals with a low socioeconomic status, such as smoking, physical inactivity, and BMI, that may contribute to elevated risk related to alcohol consumption and elevated risk for alcohol-related outcomes. To also consider contextual factors, so the social and community networks, the social environment, the drinking context, and neighborhood factors that may modify the risk one faces when consuming alcohol. To consider the conditions under which people are living and working, and that also includes the affordability and accessibility of healthcare services, the stigma one may face when drinking alcohol, and the care one may receive when showing up at the doctor. And then finally, to also consider the more fundamental causes, the economic situation at the individual level and at the country level, the socio-political environment, and also, of course, the alcohol policy environment. And last but not least, the power one may hold within society based on their socioeconomic position. So all of that together, you may have guessed it, are of course the social determinants of health. This is the rainbow diagram developed by Dahlgren and Whitehead. And the social determinants of health are defined by WHO as the conditions under which people are born, grow, live, work, and age. And all of them have to be considered when trying to understand the health inequities that we are observing. And they also have to be kept in mind when thinking about an intervention strategy, which Jakob is going to talk about. So to kind of summarize this first part of the talk and do a transition to the intervention part of the webinar, we start with the socioeconomic context and position that may be expressed by education, income, occupation, and other factors, and contextual factors that shape an individual's experience and that influence and lead to a differential exposure, both to different drinking patterns to a certain extent, as well as exposure to other health risk behaviors, life stressors, and environmental risk factors. That all together may lead to a differential vulnerability to the harmful effects of alcohol use, which is worsened by fewer buffering and coping resources and reduced access to affordable and appropriate support. And that, in conclusion, lead to these tremendous socioeconomic inequalities with more than fourfold mortality risks of alcohol attributable mortality. So what can be done in the upside for equity interventions? First of all, to counter the unequal health outcomes that we are already observing, we have to tailor interventions to the different socioeconomic groups, consider including individuals with different socioeconomic backgrounds in the development of intervention strategies, and ensure equal or even higher access for individuals with a low socioeconomic status. To account for differential vulnerability, we have to account for comorbidities and other health risk behaviors that may be present, or environmental risk factors. And then to account for the differential exposure, we have to implement and monitor effective alcohol policies. And here we have to adapt an equity lens rather than just an equality lens. And this is really where Jakob, this is the main point that Jakob is going to address in his talk. But finally, I would like to add that we have to address the root causes of inequality. And for that, we have to implement upstream interventions to improve the conditions in which people are born, live, work, and age in the long run. And these upstream approaches include policies for social protection, universal healthcare coverage, raising levels of education and skills, reducing social exclusion, and measures to reduce income inequalities within and across countries. And with that, this first part on health inequities or inequalities is complete, and I would like to hand the word to Jakob to talk about what we can do about the observed inequities.
Charlotte, Jakob, just before you begin, can I ask you one question, Charlotte? So,
yes.
why is this important why do we need to do something about reducing inequities related to alcohol consumption?
Well, first of all, as I said, all of these inequalities are avoidable and unjust, therefore, and we can decide in what type of society we want to live, in one where we have more or less equal chances to achieve a healthy life, or where some are really left behind and have 10 years less to expect to live at the age of 30. And then, of course, we could also consider it as like a group with a high risk group with high mortality risks, where when we address our public health efforts towards those that are most vulnerable and at highest risk, this is of course also a very effective strategy to improving public health overall.
Thank you. Thank you very much. So Jakob, over to you, please.
Okay, let me share the PowerPoint presentation. I hope you can see it now. Don't see any approval from your side. Yes, now I see it. Okay, great. All right, thanks, Charlotte, for introducing us to the topic. I will focus on the interventions now, on what we can actually do about to close the gap. And oh, this is going in the wrong direction. Sorry. All right, let's try it again. Should work now. Okay, let's try. Okay, I will start with, or I will basically talk about two examples that happened in Europe and have been heavily studied. So the first empirical example refers to the minimum unit price that has been implemented in 2018 in Scotland. And for all of you who don't know about this intervention, this concerns pricing of alcoholic beverages, and it basically says that cheap alcohol should not be sold. So there is a minimum, a floor price that retailers has to meet when selling their products. So it was implemented, and basically it raised the price of very cheap alcoholic beverages, and that mainly concerned off-license consumption. So because no alcoholic beverages that cheap were sold in bars or restaurants, so it concerned mainly supermarkets. And what happened is something that is hidden in this a little bit maybe complicated figure. So it demonstrates the absolute change in consumption, in weekly consumption, that is the amount of grams of alcohol that was reduced, and it describes it on across the population of drinkers. So it's the percentile distribution. With the left-hand side, you see a very low-risk drinkers, and on the right-hand side, you see the heavier drinkers. And as you can see, the reduction, so everything going below, happened among the rather heavier drinkers. So that's an important finding, and that is really interesting because it only concerned those with kind of heavy use of alcohol and not the ones who drink irregularly. The question is, why did it happen like this? Why do we observe something like this? So let's step back and talk about what actually happens when we increase alcohol retail prices. First of all, the idea of increasing prices is to reduce affordability. What does that mean again? Affordability is how much alcohol can I actually purchase with my income? We compared all the different European countries in terms of their affordability. We got the average income and the average retail price for alcoholic beverages. And we see that, for example, in Germany, where I live, you can, with an average income, buy 3,000 alcoholic drinks with your average monthly income. in a month. Well, you can also buy it in a day, but that doesn't matter. So it's a lot, and that obviously varies. And again, affordability depends on how much you earn and how much the alcohol costs you. And then if we talk about increasing prices, we want to reduce affordability. So what should happen is that the price of alcohol should go up more than your income goes up. So you actually can buy less of that product. So let's try it out with an example, because we need to understand how pricing policy works for different groups. If we, for example, take a person that purchases alcohol worth 10 euros across the whole month, that's kind of me. Sometimes I purchase a little bit more, but that's kind of my real. If we get a price increase of 10%, that would mean that I have to pay 1 euro more if I every month purchase alcohol worth 10 bucks. If I actually buy alcohol in worth of 500 bucks, 10% increase would mean 50 euros. So in relative terms, it's the same, but in absolute, it's much more. Then let's look at how this impacts people with different incomes. If I had an income of 1,000 euro, a increase of 1 euro would not be very considerable. But if I had an income and had an increase of 50 euros of my alcohol spendings, this would be quite a considerable burden to my income. Let's suppose I have an income of 10,000 euros, so I'm a very rich person, then neither an increase of 1 euro or 50 euro will really matter. We don't, I'm putting this into brackets and have to treat this a little bit with caution, because we don't know much about the very wealthy people. We don't know how they react to price changes, because they are usually not included in our surveys and so. But very likely 50 euro is not as burdensome for them as for poorer people. So rule of thumb, if we want to decrease consumption, we have to come up with an intervention that people notice, where people notice the difference. And in terms of price increase, if we increase the prices, what we expect by theory, what I just explained, is that especially people with lower incomes and those with heavy drinking patterns will reduce their consumption. So let's go back to Scotland. What happened? These are two bit more maybe complex graphs, but I'll guide you through here. First of all, left-hand side, the change in expenditure following the intervention, the minimum unit price. So we have 5 bars here. Each bar represents one group, from the lowest household purchasing fifth to the highest. So the lowest are those people, those households that buy very little alcohol, that who probably also drink very little alcohol. And then we have households with very high purchasing. And we see that their expenditure, how much money they actually spend on alcohol following the MUP, following the price increase, it mainly affected those that have already spent a lot of money on their alcohol. So we see that in about half, maybe more than half of drinkers, those who drink most, we see an increase in expenditure. But conversely, what we also see, and that's on the right-hand side, is the change in purchases of pure alcohol. So they spend more money, but at the same time, they get less alcohol. So we see a decrease of the pure amount of alcohol that they actually get for their money in the upper 20% of drinkers. So that's interesting. And that is actually why we see the following. Following the MUP enactment in Scotland, this is the paper that just came out this year. The mortality and the hospital admissions that are specific to alcohol. So it's only those where alcohol is actually coded in the diagnosis. It's not even considering all the impact on injuries or on a lot of cardiovascular diseases. So only mostly alcohol use disorder, alcoholic liver cirrhosis, and those mortality and hospitalizations decreased. And where did they decrease the most or even significantly? Only where the people live that are mostly deprived, or the areas that are mostly deprived. So areas with less public transport access, with higher unemployment and lower income, basically. Then, second example is Lithuania. Lithuania, as most of you know, Baltic country, East Europe, and it had one of the highest differences in life expectancy in Europe a couple of years ago. And between 2001 and 2014, we saw that life expectancy differences between those with lower and higher educational attainment, they just rose. In 2014, we had kind of a peak, and men were about 9 years, died 9 years earlier if they had a lower educational attainment as compared to their higher educated counterparts. And a breakup of the causes showed that the difference between the lower and the higher educated men actually was linked to all the different diseases or disease groups that we know are impacted by alcohol. So this was mainly cardiovascular diseases, but also external causes and the digestive system. In Lithuania, unlike many other countries, Charlotte has showed a slide where the difference in mortality between low and high educated people was displayed, one of her first graphs, and there you could see that cancer is actually not very susceptible to socioeconomic differences. It is in Lithuania though. And so all this was kind of the scenario in like 10 years ago. And then what happened after that? The economy grew, which generally is a good thing for a lot of people, especially if the wealth is distributed evenly. And another really important aspect is that the government decided to implement all the different best buys that the WHO has recommended in order to reduce consumption, because Lithuania at that time had the highest consumption worldwide. And this covered taxation increases, restrictions for drink driving, for alcohol physical availability, and also a near complete marketing ban. Importantly, the tax increase in 2017 was one of the highest ever recorded, and this was a very nice kind of natural experiment scenario for us to evaluate. We had a lot of studies that showed that following that increase, we saw a decrease. Following the taxation increase, we saw a decrease in all-cause mortality, but also liver and suicide and cardiovascular diseases. So that was there. But then we were asking, how did it impact education-based mortality differences? And this is what we saw. First of all, following that increase in mortality differences, or what I earlier talked about, the life expectancy difference, we saw a decrease that coincided with implementation of a series of alcohol control policies. And then in addition to that, we saw that in 2017, following our tax increase, the massive tax increase, we saw an immediate decrease in all-cause mortality differences between the lower and the higher educated men. We didn't find any effect for women. And that's also important. That effect was nullified because just roughly 1.5 years later, what you can see, the gray spike in winter 2018-2019, we saw an increase, a sudden increase in mortality differences. And that is something to keep in mind, that alcohol is, first of all, only one contributor. That's something that Charlotte has stressed, one contributor to healthcare or to health inequalities, and that other contributors can nullify the effect of alcohol. So, to sum up, we know that there are interventions that can contribute, that can help to reduce health inequalities that are driven by alcohol. But we should not forget that alcohol is only one single individual risk factors, and there are environmental, there are societal risk factors. I refer back to Charlotte's wonderful summary here. And it's a complex matter, and singling out alcohol will maybe not bring us too far in order to really close the gap. So we need to maybe broaden our perspective here. And importantly, alcohol interventions are important, but if there are other sources for inequalities that are unrelated to alcohol, that's something where alcohol interventions won't work. And importantly, depending on the country where you live, depending on how much is being drunk there, depending how much burden alcohol causes, there might be other risk factors that may be a greater threat to health equality. And just one important study showed that in 7 high-income countries, some European, some then USA, I think Australia was there as well, they showed that high alcohol intake was a risk factor for years of life lost, but compared to smoking, diabetes, physical inactivity, it was relatively small. And importantly, also people who smoke also drink alcohol, or other way around. People who drink often smoke, and they also, like, the risk factors are often they're complex, obviously, but they also tend to fall into the same group of people. One last lesson learned I want to stress is that in tobacco control policy, we were really, really successful, and I do not want to negate this, that all the control policies have really contributed to reducing use, reducing lung cancer, reducing all the health impact, the cardiovascular health impact, and that is really a progress. But it is now the leading risk factor for health inequalities in many high-income countries. And why is that? Because the reductions in smoking were not achieved equitably. So what happens, for example, now in Germany, what you see is that smoking rates are about double in those people that have never graduated as compared to those that have the highest degree of education. And that is a disparity that is right now not being seen in alcohol. So it's something that we are not facing right now, but it's something that we should not strive to achieve. So it's something that we should take care of to not repeat that mistake. So while alcohol control policy aims to reduce the consumption and attributable burden in the total population, we need to think about what do we do with all the interventions that we have available. So a lot of people, especially industry, talks about prevention and education. It's important. It's really important. We need more education. We need to strengthen the knowledge of alcohol and cancer in the population that many people are not aware of. But the problem is with traditional campaigns, we will reach only or mostly those that are literate and those who actually recognize and interact with campaigns are those with higher SES. Then brief interventions, they appear to be more successful in reducing drinking for more disadvantaged people. There's different reasons for this. We won't go into detail here. Then marketing bans and physical activity. I don't know of any studies that actually looked at the differential impact across different socioeconomic groups. Maybe anyone in the audience or from the panel can highlight any ideas here or studies. And then taxation increases I talked about in detail, so I don't have to repeat this. So the residual risk that will exist when we tighten our the policy environment, when we implement more restrictive interventions, is that we stigmatize people with alcohol use. Right now, we are already stigmatizing people with alcohol use disorder, while people can freely talk in talk shows in public about their alcohol use. That's no problem. But as we restrict the environment, then there is a risk that alcohol use will also get stigmatized in a way as a deviant behavior that is mostly practiced by low SES groups. So that's a risk that we should not forget about. And this can negatively impact healthcare utilization, and that's something that we absolutely do not want. So looping back to Charlotte's summary slide, I talked about the interventions, how they have to be tailored and what they mean in terms of alcohol attributable health inequalities, and how they have to be monitored in order to be effective. But obviously, we should not forget about the root causes of inequality, and for certain interventions, also for comorbidities, differential needs and stuff. Okay, thanks for listening, and happy to engage with questions.
Thank you very much, Jakob. Thank you very much, Charlotte. And I have a question first of all for you, Jakob. There are a number of questions in the chat, but I wanted to ask you. So you've given us these great examples of Lithuania and Scotland, where we've had these interventions, where we have real-world experiments which demonstrates outcomes in relation to reducing health inequalities. So now, do you think that's going to happen everywhere? And if not, why is it not? What are the barriers to implementing those evidence-based policies elsewhere?
Specifically for taxation, it's difficult to say or to identify reasons that apply to all the different countries. From what I've heard, some countries, especially finance ministers or ministries, they are really afraid that raising taxes might reduce revenue. So that is a fear that we are currently working on to debunk. We're looking at revenue data to see if that's really true. And then obviously in times of inflation, it's not very politically attractive to further raise prices. It's something that needs, first of all, understanding on the side of the policymakers. And but what we see in most studies and surveys is that taxation increase is actually supported by a large part of the population. So it's more, in my opinion, more on the policymaker side. And then for other interventions, there are other barriers. For brief interventions, there's a lot of barriers on the provider side, and it's difficult to really identify or give a simple answer to this, I think.
So are you more optimistic or less optimistic?
I think we're more optimistic because we compile lots of evidence currently from all the different countries, and also WHO is doing great in disseminating the evidence, something that we as researchers alone would probably not be able to on our own. So I guess we're on the right path.
Good. Okay, thank you. That's good to hear. Can I ask you, so there's a specific question in the chat, sorry, not in the chat, in the question and answer from Heike, asking, and I guess this relates to Scotland, where the final evaluation report on the implementation of minimum unit price was published, I think, just 2 weeks ago. And so the question is, did minimum unit price in Scotland increase consumption of illicit or imported alcohol?
As far as I know, it didn't. That's at least, I mean, I haven't read the entire report, But as far as I know, the illicit consumption is not a major problem in Scotland, be it cross-border shopping or like actual home brewed.
Yes, I
stuff.
think
And that's something that we also saw in Lithuania. That's also something that is that I forgot to mention is a concern by policymakers, or maybe a concern raised by industry, that people will not be able to afford legal spirits or legal alcoholic beverages. But in Lithuania, which is situated in an area, in a geographical area where unrecorded consumption is a major problem and a major barrier to effective alcohol policies. And we didn't see any. There were different measurements of unrecorded alcohol consumption in Lithuania, and none has indicated that it went up after a massive price increase or a massive tax increase that was arguably even more pronounced than the one that we saw in Scotland following MUP.
Okay, thank you. I also want to introduce my colleague Maria Neufeld from the WHO Regional Office for Europe, who's also on with us. And Maria, please feel free to come in and contribute to this discussion as well. So I want to ask both of you. So the issue, I'm going to pick up all the questions in the chat. But I also want to ask both of you. Jakob, you mentioned stigma, and you mentioned how you're concerned that potentially kind of alcohol control policies could increase stigma against people who consume alcohol, and maybe consume alcohol in particularly harmful ways to themselves and to others. The implication you made was that was not a good thing, a desirable thing. So how do we reduce stigma caused inadvertently, unintentionally by alcohol policies, and who do you think can contribute to reducing that stigma? This is for both of you, I think, Charlotte and Jakob.
Charlotte, do you want to say something? Because I've talked a lot already.
Yeah, maybe before, or I would have to think more about how to reduce the stigma. I think, first of all, it's important to consider kind of an intersectional perspective for individuals with a low socioeconomic status and other socio-demographic characteristics that may experience much higher levels of stigma already related to their alcohol use or alcohol use disorders. And then with regard to reducing stigma, I think it is similar to what we are experiencing for mental health concerns, to kind of bring it more to the center of society, to communicate that, as ChemH says, mental health is health, and similarly for alcohol use disorders, to make it more possible for people to address their concerns. But yeah, I don't have a perfect strategy to reducing stigma. I don't know, Jakob, if you have additional thoughts.
Yeah. So stigma, traditionally, some people argued we need to stigmatize people to make them aware that they are having a problem. So that was one branch of research in stigma, or in social science, that fortunately was given up in a way. Because what we know is, if we stigmatize people that have problems, they will be less likely to engage in conversations with their peers, with friends, with family, and even less likely with doctors, because they feel as outcast, and they don't want to. They just want to blend in. They don't want to be an outcast. So if we think about how do we go about in the future about alcohol control policy, we, I think, as a collective, as researchers, as NGOs, need to combine restrictive policies with information, because people need to understand that drinking alcohol, especially in higher amounts, is a risk factor, and is mainly a problem for themselves, but even for others. There is harm for others. We'll have another whole webinar on harm for others. So it's something that needs to be acknowledged in the population in order for them to understand that measures are important, are necessary, And I think this is something that can guide us to a societal understanding, or to a more equitable approach to alcohol as a risk factor.
Thank you. So I'm going to just pick up some of the chat questions. As I do so, can I ask you about research gaps? Because we're joined by the Early Career Researchers group, who are part of the EVID Action project. For you where would you suggest researchers ought to focus to reduce health inequalities in relation to alcohol consumption?
Yeah, I would address that. I think we have presented most of the evidence that is already available with regard to the effect of alcohol policies on health equity. And we performed a systematic review on changes in alcohol consumption, both overall as well as in socioeconomic groups following different alcohol policies. And we really identified barely any studies that told us something about SES-specific effects of alcohol policy. There may be a little bit more evidence on like health outcomes and mortality, such as the evidence that Jakob presented, but I think it is a major research gap that we have to address to really understand how do our different best buy alcohol policies affect socioeconomic groups. And even for screening and brief intervention, I think it depends a lot on the country context. So we need studies from different countries to understand how in their specific country context are people with different socioeconomic background affected by scaling up screening and brief intervention strategies or initiatives. I had one other research gap that I wanted to address. Where did it go? I have to think for a second, but this is, I think, a major one. Oh yeah, the other one is upstream policies. So there was also a question by Colin in the chat, like how can we evaluate or account for the effects of upstream policies on alcohol-related inequalities as well as overall health inequalities. And I think one major problem really here is kind of justifying the causal chain one is assuming in evaluating these policies. So we have to work on research methods to evaluate the effect of more upstream policies on both alcohol-related outcomes as well as health inequalities overall.
Okay, thank you. That's very clear. So I am going to go through the chat. So Laura raised the issue that reducing health inequalities is also a question of human rights. So actually that's what we're engaged with as well. I think the question in relation to has minimum unit pricing been piloted in a low and medium income country? I think Peter Rice has answered that question. Fleur has a question for you, Jakob, specifically about in your first graph, it looked as if heavy drinking women reduced much more than men. Is that right?
So yeah, that was one of the findings that we also found very surprising. That was actually something I'm not quite aware if that has ever been replicated in another study. I know there is just too many MUP evaluation studies on the table, and I'm sure that there are some study findings that do not agree with our findings, and we were also puzzled and couldn't fully explain this, although it is not entirely implausible, because when you think about women who drink a lot, and these were the women that we had where we observed declining consumption, those women may or may not be more dependent on with their income, those women who drink a lot may not be as independent with their income. So they may not be the wealthiest in the population of women. So they might be more susceptible to changes in pricing than males who are still generally earning much more than women. So that could be one of the explanations, and that's looping back also why the interaction of drinking and income or socioeconomic status is so important to consider when we talk about pricing policies.
Thank you very much, and thank you for modelling out why it's really important for researchers to interrogate what the statistics are telling you, because this idea that statistics speaks for themselves is not the case. They actually require interpretation. So thank you very much for modelling that out when you have something that's surprising. Can I ask, I think you've talked about intersectionality a little bit, but I wonder, Charlotte, do you have anything to say specifically about gender inequalities and alcohol consumption?
Yeah.
In addition to what you've said.
Yeah, I think maybe here it is important to distinguish again between absolute and relative inequalities. So as far as I know, the relative inequalities are not that far apart. They are a little bit bigger. Although no, I think there are, actually I wrote a paper on that many years ago, and I think for occupation there were some gender differences. But overall, the relative inequalities are not that different. But if we look at the absolute inequalities based on the higher level of consumption among men on average, we see higher absolute inequalities, socioeconomic inequalities among men. Now, if we try to understand more from an intersectional perspective, kind of the layering of risks and of disadvantages, it gets much more complex. We are actually working on this currently, but just in terms of the analyses, it can be much more complex. But in terms of gender and socioeconomic status, that's what I would, or I should say sex and socioeconomic status, that's what I would say.
Okay, thank you. There are a couple of questions here that I can take them very quickly. So given the effectiveness of MUP, what should we do about public industry opposition? I think that, I mean, we just have to make sure that that we do as much as possible to kind of act against kind of intervention with public health policies. That the alcohol industry has no right to be doing that, and they should be based on evidence, and the industry should not be intervening there. Can I also, I'll pick up Gail's point as well, because I'm coming from Scotland, so I can answer this. So this thing about was MUP implemented with other policies? Yes, the alcohol strategy in Scotland, it had 41 different components, and minimum unit pricing was one of the most important of those, and the evaluation considered the interaction of all of the policies, as well as broader social context in terms of drawing its conclusions. Sorry, I want to just move down and make sure in relation to, Peter, fantastic. Yeah, fantastic talk they're saying. So thank you very much, Orfley. Peter Rice has answered these questions about the Scottish approach. Thank you, Peter. Luna is saying, thank you, Jacob, excellent talk. A great way to explain for those of us recently studying about alcohol harm. Again, Gail, thanks to Jacob and Charlotte for a very insightful talk. And thank you, Tanya, who has included the final Scottish minimum unit pricing report in the chat for those who wish to pick up. So Martina says, thank you, great presentation with lots of references. Colin Angus says, I think it's very important we consider the impact of alcohol policies on inequalities. But as has been suggested, further upstream interventions, i.e. not specifically around alcohol, may also have an impact. And Charlotte, I think you picked that point up really importantly. I'm trying to see, are there any other questions? Yes. So Elizabeth is talking about stigma. The stigma must be tackled from a cultural base. I think there are loads of other points. I think that we picked up most of them. So I think I do want to kind of finish on time. So in doing so, Jakob, Charlotte, is there anything that you would like to add just to finish off? No. Thank you. Do you know, this has been such an interesting, such an important discussion, and the discussion will continue. I'm just going to share my screen very briefly to to draw your attention to the next seminars. So basically, this is the seminar series. So the next seminar is on the 12th of July, and it will be looking at alcohol and cancer, an overlooked link and decades of evidence and implications for policies. And Maria has very kindly as well kind of drawn attention to the issue of alcohol cultures and stigma will be picked up on 4th of September. So it only remains for me to say thank you so much, Jakob. Thank you so much, Charlotte. Thank you for everyone who took part in the chat, and looking forward to you joining our next session. Thank you.